Hi, everybody. I'm Dr. Kelly Baxter, and tonight I'm going to be talking about sexual health and perimenopause and menopause, what's changing, why it happens, and what actually helps. So tonight we'll
Excited.
cover what's normal, changes you might notice in perimenopause and menopause, genitourinary syndrome of menopause, foundations of lifestyle, intimacy, pleasure as a form of preventative health, pelvic health, including vaginal hormones, moisturizers, lubricants, and when you might make that referral to pelvic floor PT. And we have a special guest tonight, Dr. Kelly Sadauckas, who will be talking more about this topic, talking about desire and libido and medications that can help and hurt these things, and then when to ask for help, red flags, things to watch out for. So, sexual health matters at every stage of life. And I always tell people that if sexual health matters to you, then it matters to me. If it doesn't matter to you, then that's okay. But if it does matter to you, then you're worth it and it's worth a conversation. So, during perimenopause and menopause, we see hormonal shifts, we see stress changes, sleep, different medical conditions might come up, and relationship dynamics. They're all going to impact desire, arousal, comfort, and your ability to actually feel pleasure. So it's common, it's often treatable, and it's not a failure, and you're definitely not alone. Common sexual changes that we see are decreased libido, difficulty with arousal and orgasm, shorter and less intense orgasms, decreased genital sensation, reduced confidence or body image changes, and then vaginal dryness, burning, pain with penetration, changes in your pelvic floor, such as tension or feeling more pain or discomfort, fatigue, sleep disruption and mood changes, and recurrent urinary tract infections or vaginal infections. So, a lot of these symptoms overlap with something called genitourinary syndrome of menopause, which if you're not on hormones, basically every woman after menopause will get this. And it's basically just a lack of estrogen in the vaginal tissue, which disrupts the pH. The vaginal tissue should be acidic, so it's going to increase the pH. We see that the tissue will actually become thinner. We get decreased blood flow, decreased nerve sensation. We could see tissue changes such as narrowing of the vaginal opening, reabsorption of the labia minora. The tissue over the clitoris can actually adhere down or pull down, causing more discomfort, more difficulty with orgasm. Some people have trouble with even having a pap smear or receiving penetrative sex. And then we see more of those urinary tract infections and vaginal infections because there's a change in the microbiome. And this is related to the pH changes as well. Dr. Kelly Sadauckas will be talking more about sensation and innervation to the pelvic area and tissue changes as well tonight. But genitourinary syndrome of menopause is progressive, meaning maybe you don't feel it even at 65, but by the time you're 95, you might be experiencing moderate to severe symptoms. And some of these changes might be hard to reverse at that point when we actually have great preventative options and we have great treatments that you can start at 95 as well. And so it's definitely something worth talking to your practitioner about. It's very easy to treat. So, sexual health is biopsychosocial. A lot of people come into the clinic and they say, I've decreased sexual desire, but this is obviously a really complicated subject. So, we're thinking about the biologic reasons why you might be experiencing different hormones, blood flow, the tissue changes, like we talked about, changes in your pelvic floor, and then knowing your own body and knowing what pleasure feels like to you might change over time, or maybe you never figured that out. So, some questions to think about. Are you familiar with your own anatomy? Have there been changes? Are you experiencing any pain or discomfort, dryness, and other concerns? Then we think about psychologic changes. So, stress, mood, your beliefs, your past experiences, and then body image is a huge one. So, how many of us were raised to believe that sex was bad or that masturbation was bad? And was that bad for both men and women, or maybe just women in your experience being raised in whatever culture with your parents, with your education system? This could be a different answer for you, but a lot of us are really impacted by this. It can still be there at 65 years old. Your social and relational aspects of desire and libido, partner dynamics, communication, actually having the time, say you have children, you've got busy careers, and then do you feel safe? Safety is so important in feeling comfortable. And some of this is expressing pleasure. So, how would it feel like for you to ask what you want for? Does it cause any fear or anxiety? Do you feel safe doing that? Are you able to communicate this with your partner? Even with yourself, really discovering this about yourself can be huge and extremely vulnerable. Behavioral things like sleep, how much you're sleeping, that can really impact libido, movement and exercise, intentional intimacy. Are you able to make time for this? If people have super busy schedules. And so, when was the last time you and your partner just took time for play or for intimacy? Or maybe when did you do that for just for yourself? These can all be kind of self-reflective questions you might be able to ask yourself, and things that something like an experienced pelvic PT, an experienced clinician, or a sex therapist, or even a normal therapist would be able to talk to you about. So foundations are the lifestyle, intimacy, and pleasure. So moving your body, exercise can be hugely important with intimacy, libido, improving blood flow, and improving your mood, improving your confidence, and your sleep. Next, having good sleep, having poor sleep will actually suppress your libido. Nobody wants to do this when you're tired and exhausted, right? Regulating stress is huge. If you're very stressed, oftentimes libido is the first thing that goes. So, mindfulness, therapy, nervous system tools, and then being really intentional. You have to make the time for it. It needs to be communicated, and really scheduling even can be really important and helpful. And once again, something that someone, a trained clinician, could kind of help you with. How do you do this? How do you set this up? How do you talk to your partner about? And I have a lot of resources at the end as far as like books, podcasts, kind of getting this in your head. How do you get yourself thinking about it? All of these are tools. Regular genital stimulation is actually huge. And when we're thinking about perimenopause and menopause and this tissue that's losing blood flow, and it's maybe not getting as much stimulation as it used to be, you're not as sexually active. Maybe it's been 20 years and you have a new partner and you really want to experience this again. Something you can do is just self-play. So masturbation, vibrators, air pulsation devices, and I have a slide with pictures of a whole variety on here tonight. But all of this is actually more than just indulgence. This is actually healing your tissue. So it brings blood flow. It helps with nerves. After childbirth, there's damage. After menopause and perimenopause, you've got these changes happening. Actually, masturbation can be very helpful. And Kelly Casperson has a really good book called You Are Not Broken. And one of her quotes is, "Desire often follows pleasure and safety. It does not appear first." And I do find when I'm working with people that they're looking for desire to be quick and easy. And how do we find that? But it does take working through these steps. And I think that she makes a great point there. Vaginal estrogen is hugely important, both in the postpartum state, you can use it, but during perimenopause, menopause, and then forever on. It's the gold standard first line treatment to prevent and treat genitourinary syndrome of menopause. It's extremely safe. It's not systemically absorbed for more than maybe a tiny bit when you first start. But other than that, it's really not. For breast cancer survivors, you might find different opinions based on your different practitioners, but there's data supporting that it doesn't increase risk of recurrence or mortality. Vaginal DHEA is an alternative. It converts into both vaginal estrogen and testosterone. And sometimes, say you've been on vaginal estrogen for a while, but you're still having pain with penetration, like right at the insertion area around the vagina. There's actually a lot of testosterone receptors in that area. Switching over to DHEA might work a little bit better for you. Or say the vaginal estrogen otherwise wasn't fully treating your symptoms, or you just want to try DHEA instead. That's a great option and is also very safe. There's a lot of different formulations. You can get creams. There's a ring that will sit there for 3 months. There's tablets, inserts. So you can usually find something within your budget that works well for you as far as application and makes you comfortable. So benefits: improving lubrication, improving elasticity, improving that blood flow, reducing risk of urinary tract infections, actually reducing risk of postmenopausal UTIs by about 50%. This is huge, reducing pain with sex, and then it's very safe for long-term use and safe to start at any age. So moisturizers, lubricants, and what to avoid. Vaginal moisturizers are a tool that can be used, but it doesn't, we used to always have people, or they used to recommend using this first before you started vaginal hormones, but actually that's not the recommendation anymore. Now we start vaginal hormones first line, but you can still use a vaginal moisturizer if it helps you. These are usually given 2 to 3 times per week. You're looking for something with like a hyaluronic acid base. Vitamin E is okay. I put a couple examples on here, and then there's going to be a handout as well. But something that isn't irritating, that's hydrating, that doesn't bother you, and then using that a couple times a week, that's fine. But you might find that you don't need that if you're using a vaginal estrogen. With lubricants, water-based lubricants are the easiest to clean up, to get out of your sheets. It's safe with sex toys. For silicone, it's not always safe with all of the sex toys. You want to check with that, but it can be nice if you're having sex in the shower because it lasts a little bit longer. Sometimes just during intimacy, if the water-based lubricant isn't lasting very long, you could switch to a hybrid or to a silicone base for that. And of course, you're looking for something that for your own body isn't irritating and isn't causing any pain. And so things to kind of watch out for that is like fragrances or something that has like a cooling or a heating thing. You'll see all these marketing things, but generally for the vagina, that's not a great idea. And I have a few other things for the avoiding irritants here. I think most people don't douche anymore, but culturally that can be different around the world. And then pelvic floor therapy, we've got a great lecture on this tonight, but it's super underutilized. People don't know about it. A great reason to see a pelvic PT is having pain with intercourse, having a lot of tightness, having urinary changes such as leakage, frequency, urgency. Sometimes there can be stenosis, rectal tightness, and that's causing your pain with vaginal sex. There can be some complicated reasons why you want somebody who's really experienced to be doing the exam and somebody who can walk you through what's going on with your anatomy and then try to figure out how to make this work. Maybe a dilator makes sense for you. And there's rectal and there's vaginal dilators. We referenced pelvicfloor.com here. Pelvic Floor PT is Dr. Kelly Sadauckas who's talking tonight, and she has a lot of courses that you can do from the comfort of your own home, that you could do even before you go in and see a pelvic PT, so you have the education around the anatomy. And then once again, those sexual aids and devices. So here's a picture of just a variety. This is not all of them. There's a million different kinds, but some of them could just be like an external clitoral vibrator. Sometimes people like to have an internal vibrator, and Dr. Kelly Sadauckas will, I'm sure, talk to us more about the anatomy because the clitoris is actually quite big. It's the little bundle at the apex above your labia, but it's also down the labia majora, and she will show us more about that anatomy tonight. So there's a lot of ways of accessing that. And then sometimes people just like penetrative sex and they would like something that they can use inside of their vagina. So a lot of different options and things to look for. And they're honestly getting so much better as time goes on. And so don't be embarrassed. Everybody's buying them. It's not a big deal to try different things. You can get them on Amazon or anywhere else.
Yes, and those puffer ones, Kel, I think those are so
Oh,
interesting too. If you've never had luck with a vibratory pleasure device, try that little air puffer because that can like change the
yeah.
world.
The air pulsatile run, right?
Yes.
Kind of like
Uh-huh.
suction over the clitoris.
Uh-huh.
Yeah, people love those. Some, yeah, have like a remote.
There's some that you can sit on even that are not even penetrative, but you can like still sit on them and kind of do like a little bit of a grind to get all those clitoral nerves stimulated.
There's so many things out there, yeah. And if you have questions, of course, you can talk to us about that too. This is something that we all are very willing to talk about. Talking about next, psychological and relationship-based therapies. This is so important. And another thing I think is very utilized. So cognitive behavioral therapy and using somebody who's maybe trauma informed or sex therapist, somebody who's informed with relationships can be huge. And there is a website that AASECT website. I have it listed here on the last slide, but you can actually put in your location and find certified practitioners near you. But really, this comes back to that communication, knowing yourself, creating time, discussing things like shame, discussing body image, figuring out what works for you, really prioritizing pleasure in your life. And it can be really life-changing and amazing. And if it's hard or uncomfortable or vulnerable, I totally understand. It is for me too. I can talk to someone else about it, but me, myself, actually discussing my own health in this way is really vulnerable for me. I definitely understand that, but there's a ton of people out there who really care about this topic like us here tonight and want to make this more comfortable. And it is important. If it's important to you, it's important to us, right?
Absolutely. Amen.
So medications that can worsen libido, I think a lot of people are familiar the antidepressant class, that's the SSRI, SNRI, that can have a big impact on libido, and those can be really commonly prescribed during the perimenopause menopause time, of course. Paroxetine is FDA approved for hot flashes. That actually is likely to decrease libido. Sertraline as well, Lexapro, all of those can do that. But if it's something that you need and you need it for your mental health, that's okay. There's a lot of other things we can do, so don't just go and stop things. Beta blockers can sometimes decrease libido. Contraceptives do typically, if you take estrogen orally, that can change your libido as well. Opiates, spironolactone, tamoxifen, aromatase inhibitors, anything, if you're on any hormone blocking medications, cancer treatment, those can definitely reduce libido too. And a lot of these can work through decreasing testosterone. Then some antipsychotics, antihistamines, benzodiazepines. Some of these medications are used for anxiety, and a lot of these are actually used for perimenopausal, menopausal women when we're not using hormones and can really impact libido for some people. So it's good to know that list and then be able to work around it. And then when we're thinking about medications that could help with libido, we have systemic estrogen and testosterone. These definitely both work to help libido. So estrogen, we have many FDA approved products, and it's FDA approved for hot flashes, but it typically helps with libido as well. It's common in the menopause world, that's recognized. Even though that's not an FDA indication, that's okay. You can still use it off label. At least we do in our medical practice for this. So there's a pill, there's a 3-month vaginal ring that's systemic dosing, meaning it's a high enough dose, it's going to infiltrate throughout your body. You've got the patch, the gel, the spray, and then testosterone. It's indicated for low libido in postmenopausal women based on data. It's not FDA approved yet. Testosterone has never been approved for women, but there are testosterone products for men, and we just use, in our practice, at least a tenth of a male dose typically, or more or less, depending on what the person needs. But that's very safe. It's a very low dose of testosterone, and it does significantly help women with libido. Other FDA-approved options are listed right here. There's Addyi and Belisi. Addyi improves sexual events by about 1 per month, plus or minus. If you have sex once a year, 1 more a month is actually a pretty big deal. So I've definitely heard a pretty big variety of, if that's the average, some people feeling like it helped a lot more than that. And some people, they sleep better on it, but it hasn't helped a ton. That is one option. It's sedating, you take it before bed. And then Belisi is nice because you can kind of take it as needed. So if you knew you're going to have a sexual event tonight, you could do the injection right before then. And there are certain populations where one of these might be more appropriate. So something you can discuss with your clinician about, but there are 2 products that are FDA approved. Notably, there are 26 products that are FDA approved for men's sexual health. And these 2 are the 2 that we have for women's. And so definitely tools worth trying, but I'm really hopeful that as we increase awareness and talk more about this, that we're actually going to have more and more products available. One that I guess is not listed here is topical Viagra. You can compound sildenafil and apply that externally over the vaginal area, the clitoris, and it increases blood flow. And some women do say that helps with sensation. And then we talked about vaginal estrogen earlier. And so that improving blood flow, reducing pain, improving tissue changes, all of that actually helps a lot with improving orgasm, ability to orgasm, reducing pain, improving pleasure. So that's another one. So there are quite a few tools that we can use for women's health that I think a lot of practitioners don't even know about these.
Kelly,
So
can I ask you, how does Valesi work to help improve desire? Addyi and the Valesi, like, do they just improve blood flow? Do they like engorge the clitoris? Like, I understand how the estrogen helps, but how do the Addyi and the Valesi help?
the Addyi is more similar to some of your psychiatric medications. So it can help reverse if somebody's having decreased libido from like a serotonin drug that increases
Mm,
serotonin. It helps through
cool.
dopamine and norepinephrine.
It works on one of the serotonin receptors that is not the same as your SSRI. And so it actually causes an increase in desire instead of decrease, which is more classic for the SSRIs. And then Vyleesi is a really interesting one that it works on like a specific hormone that's part of our pleasure pathway. It's the neurotransmitter that increases with arousal. So in the same way that like when you think erotic thought, you will have like genital engorgement and those different things, we see that with Vyleesi as well. So it causes like direct genital engorgement, but then also like a mental interest. So it's a pretty wild one. I would tell women, I'm like, it can be pretty intense. It's really like you like dial up your arousal almost on demand, and it can be somewhat overwhelming to some people but really fun to others. So definitely engorgement, and definitely be at a place that you can sort of act on those desires 3 or so hours after you take the medication. Whereas Dr. Kelly was saying with Addie, it's more of like generally over time we're going to increase these neurotransmitters that are involved in our pleasure pathway, like dopamine.
Awesome. Thank you. Thank you very much.
Yeah.
Yeah. And then a couple others that I also don't have on here, but that are commonly prescribed are buspirone, which is an anxiety medication that can be either used by itself or added to your SSRI to help with anxiety, but it can actually help with libido as well. And then Wellbutrin. We commonly will add Wellbutrin to an SSRI if somebody's having sexual dysfunction. Those are other options as well. There's definitely a few things out there that can be tried. When to seek additional help. Persistent pain with sex or pelvic pain. We do want to know about this. Your primary care practitioner wants to know about it. If you're seeing me, I want to know about it. And it's something that we are sometimes getting an ultrasound for. We're doing a physical exam with a pelvic PT or with a primary care practitioner and really looking into that further. You shouldn't be having pain. And if you are, we need to figure out why that's happening. Loss of desire that causes distress. So once again, if sexual health matters to you, then it matters to us. If it doesn't matter to you, it's fine. You don't have to be interested in that, and that's okay. Recurrent urinary tract infections and vaginal infections, we definitely want to know about that. There's oftentimes vaginal estrogen might help or other options. And then anytime you see skin changes, if you're seeing thinning of the skin, it's turning whitish, or it's turning different colors, or you're seeing an atypical mole or a new mole, or you're getting irritation, you're getting more dryness, those are all things you should go have an exam for. And then a history of cancer with untreated genitourinary syndrome of menopause. There are a lot of things we can do, and I think a lot of women suffer through thinking there are no options. So key takeaways are that sexual changes in menopause are normal, they're common, and they're often treatable. We treat genitourinary syndrome of menopause early and proactively. That is the best option. It's progressive, but you can start treatment at any age. Pleasure and stimulation are preventative care, not just indulgence. It's not dirty. It can be a great thing for your health. And layered treatment works best. So thinking about biology, mind, and relationships, and that you are not broken and you are not alone. So here are some resources here. You Are Not Broken, Dr. Kelly Casperson's book. Come As You Are, Emily Nagoski does a really great job of talking about pressure around having sex, relationships, dynamics there, knowing your anatomy, what's normal, what's not. It's a great book. And then there's a lot of podcasts. Rena Malik is great. The Midlife Sex Coach, Kelly Casperson has one, and a lot of other people. Like I mentioned, the aasect.org is where you can find clinicians, therapists specifically. Ishwish is an organization centered around pelvic and vaginal and sexual health for women. And then there are apps. There's Pleasurable Audio, Dipsia, OMG Yes. It's all about pleasure and women's pleasure and education, and it's very evidence-based and informative. And Rosie, those are some great apps. And do you guys have any other favorite apps or things you send people to?
That's an awesome list.
Okay. Okay, great. All right. And a reference page. But that's all I have.
It was awesome. Thank you, Cal.
Yeah.
So I think that's just so interesting. And I think it's so wonderful if someone is on an SSRI and they're like, oh my gosh, well, and they're not quite ready to like stop that yet because they're not on the hormones, to know that they could have something that could counteract that effect. And then like the feeling of that second one, the Vyleesi, I'm like, well, that would be a nice thing to feel.
Yes, that's like the melanocortin receptor, which is that like exact pleasure and joy. So it's like, vroom.
Yeah, it's fascinating. Just to have someone be able to feel that like might be really informative.